The next talk is by Professor Nag on chronic pancreatitis, another equally challenging with splenic vein thrombosis.
When to do, when not to do splenectomy in patient with chronic pancreatitis. Splenic vein thrombosis is not uncommon in patient with chronic pancreatitis, and it is usually cause is multifactorial and initiated by inflammation, fibrosis, pseudocyst, and head mass may augment it further, and it causes left-sided portal hypertension or sinistral portal hypertension. In these patients, usually portal vein, splenic vein are usually patent and leftly is usually normal. However, in some cases, they may be abnormal. Pathophysiology, as told, is anatomical proximity of the splenic vein to the pancreas as it lies dorsal to the pancreas predisposes for this complication and all other vascular complications, as there are so many vessels lying around the pancreas. Cause is multifactorial, maybe inflammation, edema, pre-thrombotic states, and extended compression by the pseudocyst or mass, and low perfusion exists in this station, and pancreatic fibrosis. These alone or together can cause splenic vein thrombosis. This is the diagrammatic representation of the same process. This is the diagrammatic. Another this thing you can see thrombus lying in the splenic vein and this forming the collaterals and causing sinistral portal hypertension. Prevalence is very varied among varied studies, and it is lower in Western literature as Indian or Asian literature. From our study published in 2008 by Dr. Agarwal, it was around 21% in our series. One series from Maharashtra, I think it was published in 2019, that also had incidence of around 20%. One series from Dr. Saraya's group, it is around 12%. And Western series, it is just 10% or less. And events, vascular events, cumulative vascular event increases with the as time increases, and it is 3.2% at 5 years, whereas it is 24% or more at 15 years. Presentation, usually most of the patients are asymptomatic. They may have upper GI bleeding in the form of hematemesis or melena, hyperinsulinism, thrombocytopenia, leukopenia, anemia, pancytopenia. Patient may have abdominal pain, maybe due to the chronic pancreatitis or maybe due to the splenomegaly or caused by both the factors. Any patient who has got isolated gastric varices, normal liver enzymes, absence of cirrhosis strongly suggests presence of splenic vein thrombosis, especially in the background of chronic pancreatitis. Diagnosis, hematological investigation will show not helpful in the distinct diagnosis of the distinct splenic vein thrombosis. However, they contribute the assessment of hypersplenism like anemia, thrombocytopenia, or pancytopenia. Ultrasound is usually initial investigation when combined with the Doppler. It will show, in addition to splenomegaly, it will show hyperechoic thrombus, dilated splenic vein. There will be loss of flow in the splenic vein, and there will be collaterals. Endoscopic ultrasound is usually not used for the diagnostic purposes, but usually for the interventions in patient with varices or bleeding. CCT or CT angiography is the gold standard for the diagnosis of splenic vein thrombosis in patient with chronic pancreatitis. In addition to diagnosis of chronic pancreatitis, it will diagnose the splenic vein thrombosis as well as collaterals and other factors related to it. It will also diagnose pseudocyst and mass. MR angiography is very good investigation, but usually reserved for the patient with contrast allergy. Endoscopy will help in confirmation of portal hypertension, presence of varices or any other causes of non-variceal causes of bleeding in some patient with chronic pancreatitis, and it is usually used for the intervention. These are the various tabular form, various distinct modalities. Doppler ultrasound, it is around more than 80% sensitivity and specificity. It is operator dependent. Endoscopic ultrasound is basically high spatial resolution, and this is usually reserved for the intervention purposes. Contrast CT and CT angiography, more than 90% specificity and sensitivity. It is the gold standard. MR venography has got very good superior most sensitivity and specificity, around 98% to 100%, and it is usually reserved for the patient with contrast allergy, and it is costly and time consuming. It may not be available at some places. Endoscopy, more of the diagnosis of hypertension and complications, treatment for the bleeding. Angiography is more of the for the diagnostic purposes. This is usually of the historical importance. It is usually not used, but for the intervention purposes it may be useful in some cases. Know what are the factors, what are the harms and benefits of observation versus splenectomy. In observation, we can avoid unnecessary splenectomy and post-splenectomy complication, as most of these patients are asymptomatic as per literature. And there are various non-surgical modalities like endoscopic and radiological intervention are available, and which has got best outcome, and then can manage complication caused by the splenic vein thrombosis. Another way, splenectomy, it is the curative treatment. It prevents upper GI bleeding in these patients, and it can be easily performed in most of the cases when patient is undergoing surgery. And in our study, we have performed around 22%. We have performed in 9 patients, and there was no increase in such complication. There is no addition of splenectomy was not hamper the post-operative complications. So how to decide? Surveillance, patient who has got is a good risk case, asymptomatic, they can be observed. If the patient is accessible to the care, they can be observed. Patients who are symptomatic in the form of especially GI bleed, poor risk cases, patient who has got living in the remote area, there is no regular access to care, and patient otherwise requiring for the chronic pancreatitis, they can be taken up for surgery for splenectomy along with the surgery for the chronic pancreatitis. Some patient has got extension of thrombosis to the surrounding vessel, portal vein and SME, and other hypercoagulability may be put on the anticoagulant therapy. This is the multi-center clinical study published in 2024 that included 98 patients, around 40% patient received anticoagulation, and recanalization was significantly better in patient with anticoagulation in comparison to non-anticoagulant. Other study also published in 2022, blood hematological, American Association of Hematological Journal. This also approved the recanalization rate is better in patient with anticoagulation therapy. Now, what are the patients which can be managed on endoscopic therapy? Patient who has got acute or high risk of gastric variceal bleeding usually go for glue injection or in combination endosono guided coil and glue injection. This combination of coil and glue embolization has got good success rate, more than 80%. Rebleeding rate is around 11% or less, and glue embolization also prevented by this technique, and there is very good high rate of obliteration of varices with this technique. Another option available is splenic artery embolization, usually partial splenic artery embolization. This can also be done in patients who are unfit for the splenectomy. Patient has got high risk for the surgery, they can be taken as the primary modality or bridge treatment. Patient who has got no other complication to undergo surgery for the chronic pancreatitis, only hypersplenism, can be treated with the splenic artery embolization. This is the systemic review published in this year only. This is analyzed more than 500 patients. there was significant reduction of variceal bleeding in patient after post-embolization, and complete resolution of varices found in 26% and improvement of variceal grade found in 78% of cases. Now, what are the cases we should consider for the splenectomy? Patient who has got refractory or recurrent variceal bleeding, hypersplenism with significant cytopenia, splenic vein thrombosis. During evaluation, while we are considering patient for pancreatic surgery, as cure rate is very higher for this patient, all the patients should be counseled for the post-splenectomy complication. Final conclusion: in patient with chronic pancreatitis, splenic vein thrombosis is common but frequently underdiagnosed. Surveillance is adequate for the most asymptomatic patient. Anticoagulation should be used selectively in patient, especially who has got extension of thrombus in the portal vein or superior mesenteric vein. Patient has got hypercoagulability. Endoscopic glue injection, especially endosono-guided, is good for the variceal bleeding. Splenic artery embolization is an effective option for poor surgical candidates, and splenectomy cures all the complications related to splenic vein thrombosis, but patients should be counseled for the post-splenectomy complications. Thanks a lot for the patient hearing.
Thank you, sir. Any questions? So in your practice, if symptomatic, what would you first choose, sir? Would it be?
Sir, it depends on the presentation. If patient do not have any varices on upper GI endoscopy, and patient doesn't want any surgery otherwise for the chronic pancreatitis, we will watch the patient. We may put on the patient an anticoagulant. If patient has got hypersplenism but doesn't require surgery for the chronic pancreatitis, we opt for the non-surgical options, usually splenic artery embolization and other. And if patient were otherwise planning for the surgery, then we'd like to have splenectomy in these patients, especially if varices are present on the endoscopy.
Thank you so much.
So, my question was when to anticoagulate, because this sinistral hypertension will be giving rise to this isolated gastric varices. So, before the origin of the varices, you want to anticoagulate, or the development of the varices leading to the tackle of the varices first, then anticoagulate? What should be the strategy in this kind of patients?
I think it depends on the high risk. If a patient has got varices and all have not bled, I think it is better to put on the anticoagulant.
Okay, sir. And when you think of doing those splenic embolization, partial splenic embolization or splenic vein recanalization procedures, or
actually, as I mentioned, few studies shown there is better recanalization for the patient on anticoagulant. Otherwise, also there is significant number of patients can recanalize, and as per some study, rethrombosis can also occur even after the anticoagulant. So basically, therapy is for if your patient has got other risk of risk of bleeding and all other risk factor are there. Patient is not don't want surgery, and there are so many factors. You are not going to operate for the splenic vein thrombosis, and there is no hypersplenism otherwise, then it's better to go for the anticoagulation.
And is there a scope of devas in this patient? Surgical devascularization.
If varices are present, then you can devas always. It's grade 2 and higher, you can always do devascularization.